Well, I think Steve's talk is an excellent introduction to Dr. Eric Sherman. Eric is one of our medical oncologists that's been with us for many years now. And I will tell you honestly, for about the first 20 years of my career, I tried to hide everybody I could, not from Dr. Sherman personally, but from medical oncologists in general, because I didn't figure they helped most of my patients. Now I can't go through a day without talking with Dr. Sherman because of the tremendous changes that the medical oncologists have brought to us, especially in the group Dr. Larson was talking about, is when radioactive iodine no longer works for us. And we've asked Dr. Sherman to come share with us now some of the new FDA-approved drugs. These guys are really part and parcel of our team these days and really helping us to understand that small group of high-risk patients, when surgery and radioactive iodine fails us, where do we go, when do we start, and what options do we have? Eric, thank you.
Yeah, no, the world definitely has changed quite a bit. I mean, probably around 15 years ago, this talk would be about 5 minutes and 4 minutes before questions. Even like 6 years ago when we first did it, it was easy to fit everything into it. For this talk, I actually had to decide what to put in and what to leave out because so much is going on. When we talk about RI refractory thyroid cancer, we know that about half of metastatic thyroid cancers will become refractory or not be able to pick up radioactive iodine. And this inversely correlates with the PET-CT scan, which is one of the reasons we like to use it as part of our tool to try to figure out when we can still go ahead with iodine. And a lot of this is attributed to downregulation of the sodium iodine supporter. And standard chemotherapy in general has really always had really disappointing results. The one drug that's really out there for as cytotoxic chemotherapy is doxorubicin, and this has been out for a long time. It was for a long time the only FDA-approved drug. It was approved not even from randomized studies, but a lot of these phase 2 studies. The response rate actually looks very impressive, but a lot of this was done in years before even CT scans. And what we would consider response today, this would not be considered response. What we would consider response today, this drug did not have it. And it only lasted for a short period of time. And probably because of this as being the only thing, this is the reason like Mike and Steve Larson really like sort of hid patients from us all the time. It's now like a very different role, and people, when they're coming to see me, it's not coming actually even seeing the Grim Reaper anymore. But I'm almost following patients now for years without doing any type of treatment, because once we need treatment, it actually is a lot more effective than ever before. And it just works. And a lot of this is because we're not using cytotoxic chemotherapy, but we're actually doing molecular target therapy. We're actually hitting what is important in making these cancers grow and spread. In thyroid cancer, it's sort of nice in that, especially with papillary thyroid cancer, there is a lot of very good targets. A lot of translocations, RET PTC1, RAS as a mutation, BRAF as a mutation, where these are things that we can use drugs to actually try to hit, things that are driving the cancer altogether. But while the MAPK pathway, the RAF and BRAF and RAS mutations are really great targets, and even this PI3K, AKT, mTOR pathway, which are sort of these late mutations, but we do have drugs that hit them. It's really the angiogenesis pathway is where we really have had like the most success so far in thyroid cancer. And the thing about the angiogenesis pathway is that while these are targeted therapies, this is something that generally is used for all thyroid cancers. So when we talk about angiogenesis inhibition, a lot of this was really brought out because of some observations. One is that there's increased VEGF levels. VEGF is vascular endothelial growth factor levels. When the levels were increased, we noticed in thyroid cancer that the chance of recurrence was higher. There was decreased chance of disease-free survival. You see higher levels with malignant tissue than we saw with benign tissue. And when you evaluate tumors, you can actually tell the aggressiveness, that the more vascular the tumor is, the higher these VEGF levels are, the more aggressive the tumor was altogether. So this really seemed like a good target to at least try to hit in general. Now, one of the first drugs that was looked at, not the first, but one of the first was sorafenib. And sorafenib is a tyrosine kinase inhibitor. It's a pill. It targets all these VEGF and PDGF and RET, or things that are also important for the vascular pathway. It also is a RAF inhibitor, And actually, when it was first used, it was used because we thought it would work against tumors that had a BRAF mutation. It was done in the time that BRAF mutations were first found. And it actually doesn't work that way, but at least that was one of also the initial reasons why it was looked at. There are two big studies that were done, phase 2, so just single arm, one by Ohio State, another one by University of Pennsylvania. And you saw sort of good response rates with each one of these. No, it's not 90%, but at the same time even if you didn't have what we call a major response, which means the tumor shrinking half or greater, what you can actually see is the tumor was still shrinking. So this stable disease doesn't mean the disease stays just where it is. A lot of these are tumors that shrunk by 5% or 10%. The one thing that was a little bit unclear between the two studies is that at least in the Ohio State study, it seemed like this only really worked in the papillary subgroup. But in the Penn study, you really did see it work in all three subtypes. So this went forward to what we call a randomized study. A randomized study is a prospective study where half the people get the investigational treatment and half people get standard treatment. And initially, people, years before this study, we all thought maybe doxorubicin was the standard treatment. But really, when this study came around, the FDA sort of even agreed that there really wasn't a true standard. And the randomized study was the drug, sorafenib, against placebo, so against no treatment at all. It allowed that when the tumor started to grow, that patients could then be crossed over and receive the drug. So everyone on the study was able to get sorafenib, but in the beginning, only half the people actually got sorafenib. The primary outcome was progression-free survival, and that's one of the things you always think about with a crossover study. The big advantage of the crossover study is that it's attractive for people taking part in it because you're going to get the drug. The disadvantage is that everyone really wants to know how effective these drugs are, and if you don't know how this is going to affect the two outcomes that are most important in patients, which is overall survival, is this going to make me live longer, or is this improving my quality of life? You sort of lose that with the crossover part. So we end up using progression-free survival as a surrogate, but it's not a perfect surrogate at all. 417 patients were randomized, and this study was with patients who had no prior treatment. And that's important when I talk about some of another phase 3 study. What this showed was that sorafenib is an active drug. People who were on it had a median of 10.8 months. It doesn't mean everyone was on 10.8 months. Half the people were able to stay on drug for a lot longer than that, but half were 10.8 months. The thing is the placebo group had a progression-free survival of 5.8 months, and that sort of just pushes the whole idea that just because the disease is metastatic and it's radioactive iodine refractory, it doesn't mean that a patient's in trouble. People can live a very long time with absolutely no treatment, and about 20% of the people actually on the placebo arm had no progression for over a year. So it is but you do see a benefit. It's not as good a benefit as we would have liked, but it definitely is a benefit. The overall survival was not significant between the two arms, and that was part of the idea of there's a crossover. So this is something that would be very difficult to show it together. But most of the people who did get placebo did cross over and receive sorafenib. Here are the progression-free survival curves. If this was against anything but placebo, this would definitely be considered a gigantic winner. But even with this, it definitely shows that this is an active drug in this cancer. Response rates were closer to what you saw in Ohio State, about 12%. The things that have to be considered with it is that these drugs do have toxicities. Almost near 80% of people need to go into a lower dose of the drug. So the drug that we start at, the dose we have to start at, a lot of people do have to go down. Now, that being said, the placebo arm, 30% of people have to go down. So there's a lot of effects that can happen to make us go down the dose that have nothing to do with the drug, but it just has to do with other things going on. The other drug out there is this drug called lenvatinib. Lenvatinib is also an oral drug. It's a tyrosine kinase inhibitor. It hits some of the same targets as sorafenib, VEGF, RET, PGF, KIT. The big difference is this thing called fibroblast growth factor receptor. Some people think that this is a mechanism of resistance to these vascular agents, to these other VEGF agents. So we think that this might be able to overcome resistance that the other tyrosine kinase inhibitors are not able to do. And this went through a very similar phase 3 study-like decision. People either received drug or placebo. But the big difference with this is that this allowed patients who actually were on another drug beforehand. So people who were on sorafenib and had progression could still go on to this study. It wasn't just treatment-naive patients. This is a very, very big difference. So even against placebo, this really showed that people who were on lenvatinib, that they had a progression-free survival of 18 months. So half the people, a lot longer than 18 months. And even the placebo arm actually did a little bit worse. And there's a lot of different explanations for it. But this one, that even if this is going against placebo, this looks like a very, very active agent in this cancer. When you look at response rates, these are also extremely high. The overall response rate is 65%. So basically 65% people, 6 to 7 out of every 10 patients, had tumors shrink in half or greater, while still a good number of people still had some shrinkage of the disease. Furthermore, what has never been seen with any of these drugs before is that they actually reported some complete responses. So that means the tumor shrunk to such a small size that you really couldn't see this on imaging. And 4 of these patients had it. It's not clear whether that actually really means cure of the disease. We don't really think it probably means that, but at the same time it really can cause the tumor to shrink amazingly down. The other thing is that it seems to work very quickly. Within 2 months, people had already started to see these major responses with this drug. The other thing, and this is very important, is that while the drug looked great in the people who never had prior treatment, when you looked at the group that had prior treatment, this looks almost or basically as good as this other group. So you still had gigantic benefit from this. It didn't seem like it decreased one bit. Whether you were already progressed on a different VEGF agent or whether you had this as your first treatment ever. The drug does have its side effects, so it's just because it works great, it doesn't mean you have to think about other things. A good number of people will have dose reduction of the drug. There are a few people who will die on this treatment, and that really has to be considered with it. Now, that's true with all these drugs, and it's a very small percent. But it's there that about 6 patients ended up dying from events that we think were related to this. And when we start thinking about when we're going to start treatment, while there's no question the benefit is really high with this drug, at the same time as you do want to consider side effects. Now, when we look at all these drugs that have been looked at, it's sort of amazing like what's out there compared to what was even available 6 years ago when I first came to Memorial. When I came to Memorial, we had some of these phase 2 drugs. The only thing that was FDA approved was doxorubicin or adriamycin. None of these drugs were either FDA approved or what we call compendium approved. And compendium approved means that the NCCN committee decided that even though there's no phase 3 data out there, that these drugs are effective enough that they should be allowed to be, people should be able to be treated with them. And Medicare and other insurance companies say that if the NCCN committee is so confident about that, then you can go use them and insurance will pay for it. What you see here is that a lot of these drugs exist. They all have some good response rates. But now we have 2 drugs that are FDA approved, so went through very high hurdles, both sorafenib and lenvatinib. Even this other drug, vinditinib, has finished the phase 3 study, and we're just waiting for the results, and that has a chance of being FDA approved. But when you look at compendium approved, sunitinib, pazopanib, axitinib, and vinditinib are all compendium approved. So now when someone comes in and sees a doctor for one of these drugs, we have 6 drugs that we can use off of a clinical trial for this. And for the most part, people have been able to show that you can go from one drug to another drug to another drug and still have some efficacy going on. So it's not like you could just choose one of these drugs and that's the last one. People are able to go from one to another. The 2 things to always point out a little bit, one is this study we did with a drug called VEGF trap. That's a very powerful VEGF agent. That was one we didn't get any responses. A lot of stable disease, but not any responses. And it really starts to suggest that there's something else going on that we don't totally understand. And these other drugs all hit so many different targets that we really don't have a great understanding. Is there a specific target that really is helpful for treating this cancer, or do you need to hit multiple targets? And these are things we still don't understand altogether. The other thing I'm going to talk about a little bit later is using another drug. So instead of using one drug, use two drugs. And everolimus is something called an mTOR inhibitor. And from there, at least in the phase 2 study, our response rates look like almost as good as you're going to see with lenvatinib, or basically the exact same. So the conclusion is that these receptor tyrosine kinase inhibitors, so not cytotoxic chemotherapy, have extremely good activity in differentiated thyroid cancer. A lot of them are now accessible off of a clinical study. Sorafenib and lenvatinib are now the two FDA-approved drugs, and I think they should be considered sort of the standard of care. As I said, phase 3 with vititinib is not yet reported. The one thing is that there is no head-to-head comparisons. So all these are individual studies, and you really can't always put one to another, but at the same time, of the two randomized studies, lenvatinib really looks quite impressive, and more impressive than I think we see with sorafenib. That being said, sequencing of these drugs is not clear. And the reason I say that is it would seem logical you should use your best drug first. However, this is a long-term building process. Being like a Philadelphia fan, and a big Philadelphia Flyers fan, you always see the problem is they're always thinking about what they're going to do for that season, but not really thinking how to build the team in the long run. And that's the same thing you got to do sort of with these drugs, is you have to not think about what am I doing just today, but what am I going to be doing next year, 2 years now, or 3 years from now. It is very clear from the data that lenvatinib works just as well after people have had other tyrosine kinase inhibitors. It is not as clear yet, although it could definitely be true, that after you get lenvatinib, do the other drugs work just as well? And when we think about having to sequence them, these are things that we have to try to determine, and we just don't have that data out. The lenvatinib data, phase 3 says definitely it works in the second line, but it does not, there's no data that was collected to say how these other drugs work after lenvatinib failed. And this is probably going to be the next series of studies that are going to be going on, is to try to get a better understanding is once one drug doesn't work, what drug do you use next? Does it work or does it not work? The next thing we'll talk about is sort of this MAPK pathway in thyroid cancer. And this is something I think we always think is sort of like the next big area outside the VEGF target. We know there's a lot of genetic alterations to thyroid cancer, especially papillary thyroid cancer. BRAF is the most common of them all. But there's also other things along the pathway, including red PTC translocations, as well as TERK rearrangements. RAS mutations are seen. And when you look at papillary thyroid cancer, about 70% of them will have mutations along this pathway. So this is a very attractive pathway to try to target. In addition, we're going to see pathway in a very parallel pathway, the PI3K, AKT, PTEN pathway. And this pathway is probably at later mutations, except for maybe in HER2, and we'll talk about that a little bit, but it's just as important. And we have drugs that target that pathway as well. We know that there's, as I said, a different concordance, meaning that tumors that have BRAF mutation, if they have it in the metastatic site, they almost definitely have it in the primary site as well. So this seems to be something you're going to see in all the cells. The PI3K AKT pathways are a little bit, mutations are a little bit different. There's some discordance. So those are sort of later mutations. You may find it in a distant met, but not in the primary tumor. And you have to consider those factors when you're thinking about treatment. There's only been one published, so not presented, not finished, but one published study looking at drugs in the pathway as treatment for metastatic thyroid cancer. And that's with this drug AZD6244 or solumetinib. This is an uncompetitive inhibitor of MEK, so this is the pathway right after BRAF, or the protein after BRAF. And there was a phase 2 study done in papillary thyroid cancer, and the response rates for this drug really were not that great. Only one major response. And that's, so it was sort of a failure looking at a MEK inhibitor with it as a treatment for it. But probably part of the problem I think a lot of people felt was that you need to do something stronger against the BRAF mutation, not just try to hit something later in the pathway. And like I said, BRAF mutations are the most common seen in papillary thyroid cancer. They may portend to a worse prognosis. They may increase the risk for radioactive iodine refractoriness. And what's happened after that MEC study over the last few years is that these drugs, there have been drugs that developed that specifically target this BRAF mutation. Now, they were actually made for a lot of them for melanoma, where you have the exact same mutation, and these drugs work extremely well there. But it makes a lot of sense to try to look at these in thyroid cancer. And the two in melanoma that have been approved are vemurafenib and dabrafenib, although there's a lot of newer drugs that are being investigated as well. So naturally, people thought, let's do a phase 2 study with vemurafenib. And this was a phase 2 study in patients with unresectable disease. Patients all have to be RI refractory, evidence progression-free in the last 14 months, very similar to what's required in the sorafenib and lenvatinib studies. They did look at two different cohorts, those who never got drugs like sorafenib and those that did get drugs like sorafenib. And the idea was to look to see what happens in terms of disease progression. The rationale for this was that in the phase 1 study with vemurafenib, they did include 3 patients with thyroid cancer. And in those 3, 1 had a major response, the other 2 had good stable disease. So at least the early data, but only 3 patients looked like that this may have activity. So the phase 2 study was done and has been completed. The results of it showed that in the group that were treatment naive, the response rate is not bad. It's about 35%. And 35% is about as good as you see with most of these other drugs. 23% were stable disease at 6 months, so a little bit harder than just stable disease, but that stable disease that lasted. In the group that did get VEGF agents before, and this is a little bit less clear, although these could be definitely a lot more aggressive tumors, you end up seeing about the same response rate, but fewer patients that actually have stable disease. So you're seeing like activity with this. And this study will actually be published very soon. But it does show that a BRAF inhibitor by itself has some activity. We definitely would like to see better activity with it. In melanoma, these drugs have very high response rates. And there's a lot of studies going on right now trying to see if we add a second drug, can we make these response rates a lot higher? There is a randomized study with a drug called trametinib, another MEK inhibitor, where you're using a BRAF and MEK to really try to inhibit that pathway. There is a phase 1 with dabrafenib and pazopanib. So pazopanib being a VEGF TKI with some data that's actually from melanoma about a pathway resistance. There's a phase 1 going with dabrafenib and lapatinib. That's being done here. And that's based on work done here by Jim Fagan, where at least we believe is that the reason BRAF inhibitors don't work as well in thyroid cancer compared to things like melanoma is that there's upregulation of a different pathway. And this other drug, lapatinib, actually blocks that pathway. And we've had some good responses already in that phase 1 study, even though we haven't got lapatinib to the full dose yet. There's also these redifferentiation studies, and Dr. Larson sort of alluded to these. These are studies using these drugs to try to make the tumors more sensitive to reactive iodine. Dr. Fagan's going to talk about these in great detail after lunch. Is one of the more exciting things in research for thyroid cancer, and it's actually a good reason not to leave after lunch, because it's good. So BRAF and MEK inhibitors are really like interesting targets for target therapies for thyroid cancer. There's a high frequency of mutations in here. Several studies have begun to investigate this, and while there's no published data with the exception of the solumetinib study, these studies really look very exciting, and it's hitting a different pathway than the VEGF. So the VEGF stuff has been pretty much more established, but this really looks like something else to be able to use as well, at least in selected patients that have mutations along this pathway. So this is sort of, I think, a very big area that we're really in the middle of investigating, and we're going to have answers to pretty soon. The other pathway, which has not been published as much, is this mTOR pathway, in inhibiting mTORs. And we have drugs out there that do this. You know, when we talk about this pathway, this is there's a lot of reasons to think that this may be very important. There is some proliferative effects of that are TSH being dependent on mTORC activity. mTORC1 activity is required for the growth-promoting effects of oncoproteins in the MAPK pathway. There's a syndrome called Cowden syndrome, which have mutations of PTEN, so something along this pathway, and we know that 10% of those patients will get thyroid cancer. And there's this study from Penn where they looked at the sorafenib data and looked at the tissue and showed there was this inverse correlation of phospho-AKT expression and response to sorafenib, suggesting this may be a mechanism of resistance or why some tumors don't respond to sorafenib, and adding something that inhibits this pathway may actually improve that response. And I'm going to show you data that actually might very well be correct. The other thing is Hürthle, and that's sort of like the stepchild of thyroid cancer. Most thyroid cancers are papillary. The other large group is follicular. Hürthle is a small subgroup, and I think a lot of people for years had always thought that Hürthle was more of a subgroup of follicular thyroid cancers. There's good data here from Tim Chan and Ian Ganley really showing that Hürthle is actually is more separate from the other two, and that the drivers of this are different than what you see as drivers of papillary thyroid cancers. And it could be that the PI3K, AKT, mTOR pathway might be extremely important to this. And that I'll also show a little bit of data for. So there's a study done with sorafenib and everolimus here. And everolimus is an oral inhibitor of mTOR. It was just a straight phase 2 study. This did not allow prior sorafenib, but it did allow medullary thyroid cancer, and we put in a total of 36 patients. And when you look at our responses in the differentiated thyroid groups and take away the medullary, we saw response rates of 61%. This is no different than what you see with lenvatinib. And in fact, it's just the same, if not better, than what they saw with the lenvatinib phase 2 data. So really high response rates here. Even in medullary, which I'm not going to talk about as much, but even in medullary, response rates were 40%, when sorafenib alone has response rates of less than 10, probably closer to 0%. So you really see this combination being active even in medullary, but in differentiate, really very high. The group that really did the best was Hürthle. So it's like, if you remember back when I showed what in Ohio State study, the Hürthle tumors did not respond at all. Here we see very high response rates. Really, when you calculate this together, 78%. When you look at the what we call the plot of how these tumors shrink, you can see a lot of these tumors shrink quite a bit. These are 2 Hürthle cells. You can see that they went down by more than 70%. This is not a 70% decrease in volume. This is a 70% decrease in diameter. So the volume decrease is actually much higher than what you see right here. And you can see that a lot of these orange stripes are below this line of what we consider a major response. Really, and this orange group are the patients with Hürthle. I said, when you look at what happened in Ohio State, 0% response rates. Here we're seeing 78% response. Here progression-free was 4.5 months. Here we're seeing 17.3 months. So it looks like that the mTOR pathway, and adding that to sorafenib, really has some benefit. And there's actually now a randomized phase 2 study going across the country in Hürthle thyroid cancer. So this taking Hürthle out from the rest and looking at this as a separate group altogether. And patients are being randomized to either receive sorafenib alone, the standard of care, versus sorafenib and everolimus. If you get sorafenib and the tumor progresses, patients then get everolimus. And this is going to answer more than one question. So besides seeing, does the addition of everolimus lead to a benefit? One thing we don't know is, do you even need sorafenib? Is it that the everolimus, the mTOR inhibition, which is really important? So either patients will receive just one drug each, first receive sorafenib, then receive everolimus, a lot less toxic regimen, but have an idea what's the activity with everolimus, or is the benefit the combination of the 2 drugs, which is the other arm? And it's going to be interesting to see what happens at the end of the study. But this is the first time, as far as I know, first time ever that anyone's really been looking at Hürthle as a totally different group than everything else. We've done papillary lung studies, but we've never done Hürthle lung studies. So now I'm going to talk a little bit about medullary thyroid cancer. Medullary, about 20 to 25% of medullary thyroid cancers we know are hereditary, and it's really the RET mutation that, well, not really, it is the RET mutation that is the cause of these hereditary tumors. But even in those that are not hereditary, a lot of them are driven by RET. So it made sense that if you could get something that inhibits RET, then that's what we should go forward and use that. So Ventitinib was sort of the first drug that was really looked at. And Ventitinib is an inhibitor of RET, and a lot of the work of Sam Wells really sort of showed this. It also inhibits other things that might be important, VEGFR, EGFR. And with good phase 2 data out there, they went through a phase 3 study. Now, the phase 3 study, people were randomized to receive drug or placebo. If you got placebo, you then cross over and receive drug. So this is a very nice patient-friendly, but it doesn't always answer the real question about, is this helping in terms of overall survival? Here we see good progression-free survival advantage in the group that got Ventitinib. The placebo group, though, did extremely well. This study did not require progression to get onto the study, and it really sort of pushes that while Ventitinib is a very active agent, not everyone needs to be on a drug, just because you have metastatic cancer. Watching these patients will work just as well. And sort of half the trick is trying to figure out when you should start one of these drugs. But a little bit unlike the sorafenib, here you see very high response rates, 45%. So the response rates, there's no question this is an active drug in medullary thyroid cancer. The second drug that was looked at is a drug called cabozantinib, or XL184. This is also was found to target RET, but also besides hitting VEGF, it also hits this other target MET, which a lot of people also felt might be a good target in medullary thyroid cancer. And so people went to a randomized study, almost exact same, but this one was a little bit different. What you see is no crossover. So this is finally a study that didn't allow patients to cross over from one to another. Always an issue is that even though there was no crossover, there's a lot of ways to get other drugs after this that probably hit this target. So it's not as clear as we would like, but at least this way, and we might have a better idea about the benefit of cabozantinib. And what you see here is a very big progression-free survival advantage, 11.2 months to 4 months. So here you're really seeing another drug that looks like it works. And because of these phase 2 studies, both these drugs are now FDA approved for medullary thyroid cancer. It's sort of the same issues as we saw with differentiated thyroid cancer. We don't know how to sequence them. We know we could often go from one drug to another, but which is the best first drug and which is the best second drug, we don't have an idea. So what we have is now these 2 good FDA-approved drugs. It's still unclear what is the important target. Is it always RET? Or because these drugs hit so many different targets, is another target just as important? We don't know what order to use these drugs in. They have a little bit different toxicities. The toxicities sometimes drive what we choose, but we don't know which is the most important between the two. It's also still a little bit unclear when to start medications. Everyone has a different rule with it. When these studies first started, people were started much earlier than they probably would be today. But even now, you'll see some disagreement with different physicians on when to start and when not to start. And I've definitely seen patients, who have started these medications, looked at it, and sort of couldn't find clear reasons why they should have started really at that time. It's always nice to shrink tumors, but that's not what, at the end of the day, while everyone's like high-fiving each other and saying, this is fantastic, what everyone really cares about is this going to make me live longer, and is this going to improve my quality of life? And that's sort of the areas we still need to try to figure out is, at what point are we doing that? Also, the other thing that needs to be explored more is that there was a secondary analysis in the cabozantinib study, and it really showed that tumors with a RET and RAS mutation, which are the majority of medullary thyroid cancer, but it was these tumors that had the real benefit, and it's a little bit less clear that if you don't have those mutations, how much benefit are you really getting from these drugs? That being said, there are other treatments that are not FDA approved that seem to be effective. So we have this one, even though it's always considered chemotherapy, it's not considered very active. We have a good chemo regimen that actually we've seen very good activity for. The other thing is this whole mTOR inhibition issue. So at least with sorafenib and everolimus in that study, we were getting a 40% response rate, really suggesting that mTOR inhibition may play a very big role, especially with tumors that, with drugs that inhibit RET. And we're actually doing a specific phase 1 study looking at that, where we combine faditinib with a next generation mTORC1, mTORC2 inhibitor. And we'll hopefully start having answers in the future about even more treatments being available for medullary thyroid cancer. So that was a lot of stuff, and you'd be surprised about how many things I probably have left out. But I don't know if anyone has any questions, or we'll get to questions another time.
So we've come a long way from me hiding patients from Eric to now not understanding what the heck he's doing down there. But he's got a lot of reasons to do a lot of stuff. It's really an exciting time.